Okay, thank you for the introduction. So I'm Shingo Chihara. I'm with the section of infectious disease at Virginia Mason in Seattle. And my talk today is on HIV. Let me advance the, can you advance the slide? I have no financial disclosures. Next slide, please. So the objective today is describing the current HIV testing and treatment guidelines and how medications adherence support the U equals U concept, describing the target population for PrEP and PEP, and to interpret the guidelines for managing a patient on PrEP in the general practice setting. Next slide, please. So this is the order of my talk. Next slide, please. So first, I'll be talking about HIV testing. Next slide, please. So with that, this is a table on transmission rate of HIV. So this table shows the whole HIV population divided in different subgroups. So the top two, so these are patients who are unaware of their HIV status. So if you look at acutely infected and non-acutely infected, about 15% of patients with HIV don't know that they have HIV. And if you go all the way to the right, the transmissions generated, if you add those two groups up, that comprises 37% of the transmissions. So 15% of the HIV population, but responsible for 37% of the transmissions. So the lower part, so these are patients who are aware of their HIV status. Unfortunately, there are 22% who are not in care, and they are responsible for 42% of the transmissions. The middle one are the patients who are in care, but the viral load is still detectable. That's about 11%, and responsible for about 20% of the transmissions. And the very bottom are the ones who know that they have HIV. They are in care, and the viral load is undetectable now. And that's 51% of the HIV population right now. And the key is the transmission rate and the transmissions generated. So it's 0. So those patients who are getting care on ART and with a undetectable viral load do not transmit HIV. So the goal is to really diagnose these patients, get them in care, and get everyone into that group. Next slide, please. So first step, really, so getting that 15% aware to know that they have HIV so that they can get care and then be started on medications. So there are 3 types of testing nowadays. Antibody testing, which is just the antibody. It's most of the rapid tests, and there are some HIV self-tests that are available too. So from the exposure to positivity, it takes about 3.5 weeks, so 23 days at the earliest. The regular blood work that we do nowadays, it's mostly HIV antigen antibody testing. We also call it 4th generation HIV testing. We could pick up HIV as soon as 18 days, so 2.5 weeks. Lastly, the nucleic acid testing, that the other name for it is viral load testing that we do. So we do that for patients who have HIV. I'll talk about that for PrEP later. And also, if you're suspecting someone has acute retroviral syndrome, then these tests turn positive a little bit over a week, so as early as 10 days after exposure. Next slide, please. So this is the recommended HIV testing algorithm from the CDC. So right now, when we screen for HIV, really the test that we recommend is the antigen antibody immunoassay. So not just antibody, but antigen antibody. If it's negative, they're negative. But if it's positive, what happens is it's reflects to this differentiation immunoassay. Maybe 10, 15 years ago, we used to have the ELISA, which was a screening test, which was antibody testing, with a reflex to Western blot testing. You may remember that. But the thing with Western blot testing is that it's really labor intensive. It takes a lot of time, and it's really experience dependent. I think you remember the urinalysis, the test urinalysis strips that Dr. Pottinger showed. It's similar to that. We have to see is there a band there or not. So nowadays it's more automated. Turnaround time is quicker. So it's this antibody differentiation immunoassay that's used to confirm HIV. So with that, if the HIV-1 antibody is positive, it's HIV-1. If HIV-2 is positive, it's HIV-2. HIV-2 comprises less than 0.1% of HIV in the US. It's mostly in West Africa. You could have co-infections with 1 or 2. And all the way on the right, you could have a immunoassay that's positive, but the HIV-1 and the 2 are negative or indeterminate. In those cases, the next step to do is to the nucleic acid testing. So that's the viral load. So if the viral load is high, the patient may be in the window period, and the HIV-1 nucleic acid testing would turn positive. And usually it's really high too. And that would determine that a patient has acute HIV-1 infection. If the HIV-1 nucleic acid testing is negative, then it's negative for HIV-1, but you still don't rule out HIV-2. Although it's very rare. Nowadays, there aren't too many labs that do HIV-2 viral load testing, but UW Lab Medicine is one of the places. The other thing you could do is wait 2 to 4 weeks to see if the immune system mounts that antibody response, and repeat that HIV-1 to antigen antibody immunoassay, because by then, if they were in that window period, the antibody production may be adequate for the test to turn positive. Next slide, please. So who should get tested for HIV? So first, ones that you clinically suspect that the patient has HIV. Number 2, the possible HIV exposure I'll talk about with PEP and the PrEP portion of my talk, and then routine screening. Next slide, please. So for acute retroviral syndrome, so these are some of the symptoms that patients who are acutely infected with HIV experience. The incubation period is usually 7 to 28 days, 1 to 4 weeks. The most common symptom is fever, 75%. And as you can see, fatigue, myalgia, rash, headache, and so forth. So these are very non-specific symptoms. Right now you can say, could this be monkeypox or COVID or rhinovirus or CMV or mono, or there are many things that would be on your differential. So with that, it really is important to have acute HIV as one of your differential diagnoses, because if you don't test, we're not going to know that the patient has HIV. Next slide, please. So these are some of the chronic symptoms that the patient may have, or actually these are diagnoses. So for HIV/AIDS, so these are some of them. So whether it's opportunistic infections like candidiasis, coccidiomycosis, cryptococcosis, CMV disease, and so forth, or it could be malignancy as well, invasive cervical cancer, or the effects of the HIV virus itself, which are HIV-related encephalopathy or wasting syndrome. Next slide, please. And these are some other opportunistic infections and malignancies that could occur with prolonged HIV infection. Next slide, please. So this is a paper from JAMA, really regarding USPSTF recommendation for screening for HIV infection. Next slide, please. So USPSTF and the CDC really recommends everyone, so adolescent and adult age, it's a little bit different, so 15 to 65 and 13 to 64, to at least once as part of their routine health care, just like you think of it like lipid profile or diabetes screening or cancer screening. It really should be one of the things that should be tested. All pregnant women should be tested too. The thing about this is that we are really, we try to risk stratify, right? So someone has HIV or they're MSM, yeah, we do screen for HIV, but it really is important just to test, because there are patients where if it's a 50-year-old monogamous female, maybe you felt that the patient is not at risk, but it really is important to get that one test, or you're not going to pick up that 15% of the population who don't know that they have HIV. So there are times where I have HIV patients and they don't know where they were exposed. So it really is important to screen for HIV. And there are studies, this has been going on for years, it has been recommended for years, but the compliance rate is about 40 to 60%. Next slide, please. So PrEP, so pre-exposure prophylaxis. Next slide, please. So this is use of antiretroviral medications to prevent HIV infections. So it's used by people who does not have HIV, who may be exposed to HIV through sex or injection drug use. Next slide, please. So there's a guideline from CDC from last year that I'll go over. Next slide, please. So with that, I will go over 3 slides regarding efficacy of PrEP in different populations. So the first is the MSM. This was published over 10 years ago. So this is for seronegative men or transgender women who have sex with men. So FTC-TDF is one of the ART, antiretroviral therapy, versus placebo, and followed for a median of 1.2 years. There were 100 infections, 36 in the ART group, 64 in the placebo group, and there were 44% reduction in HIV. Next slide, please. So this was for heterosexual discordant couple from Kenya and Uganda. So this was published 10 years ago. So this one had 3 groups, TDF tenofovir, TDF FTC versus placebo, followed up for 36 months. There were 82 infections, 17 in tenofovir, 13 in FTC TDF, and 52 in placebo groups. So relative reduction of 67 to 75% in the ART groups. Next slide, please. So this is for injection drug use. This was published 9 years ago. There were 50 infections, 17 in the tenofovir group versus 33 in placebo, and about 50% reduction in HIV incidence in IV drug users. Next slide, please. So who should get PrEP? So this is a recommendation from the CDC. So someone who's for sexually active, so anal or vaginal sex in the past 6 months, and 1, have a HIV positive partner, 2, have a bacterial STI, so gonorrhea, chlamydia, syphilis over the last 6 months, or number 3, inconsistent condom use. Or for persons who inject drugs, number 1, HIV positive infecting partner, that's more sexual than IV drug use, but number 2 is sharing injection equipment. And there are studies to show that about 1/3 to 1/2 of people who inject drugs in fact do that. Next slide, please. But what's relatively new in the newest guideline is really anyone who asks for it, anyone who's interested should be assessed for PrEP. So that's actually a big chunk of my practice because they go see their primary care physician and they were interested in PrEP, but the primary care physician was not comfortable doing it, and then they'll refer to infectious disease clinic, and then we end up doing the PrEP prescriptions. Next slide, please. So clinical eligibility. So the first thing is we want to make sure that the patient does not have HIV currently. So the first one is to getting a negative HIV screening 1 week before the prescription. Number 2, we want to make sure that they're not ill from acute retroviral syndrome, that the negative test is in fact not a false negative, because we don't want the antiretroviral therapy does not fully treat HIV. It's only used for prevention. And what it does is that it could result in resistance. So we don't want to undertreat with a PrEP regimen when in fact someone has HIV. And number 3, for certain regimens, we want to screen their kidney function. And number 4, if they're obviously, we want to make sure they are not allergic to any of these medications. Next slide, please. So there are 3 medications that are FDA approved. Number 1, this is the oldest one, FTC tenofovir disoproxil fumarate, TDF. The brand name is called Truvada. This was approved in 2012. The generic equivalent was approved in 2019. Number 2 is FTC TAF. It's a tenofovir, but a different formulation of tenofovir, alafenamide. The brand name is called Descovy. This is 1 tablet once a day as well. The newest one is cabotegravir, the third one, which is an injection. That was approved late last year. So the difference between 1 and 2, they are both 1 tablet once a day. What we know about the FTC TDF is that it could injure in the kidneys, and it may lead to, or there is association with lower bone mineral density. So number 2 is that TAF FTC is more kidneys and bone friendly, but what we know about number 2 is that there are rise in weight over a year, and also a rise in LDL. So there are pros and cons with each one. The other thing with the pill itself is that the pill itself is smaller for number 2 than 1. Cabotegravir is IM. Right now, we have not implemented in our clinic yet because of it's more about the logistics, like who is going to do the injection, where is the patient going to get the medication itself, and is it covered by insurance? So we're actually at a point where we're having it run through the P&T committee in our hospital right now, but we haven't started the cabotegravir injections yet. Next slide, please. So the dosage, as I said, for the oral medications, it's 1 tablet once a day. And we really see them every 3 months. So we don't do more than 90 supply at a time. And when I see them, initially we really say we only do refills when they are present for their appointments. And I don't do refills just over the phone or per request. For the TDF FTC, so that's approved for MSMs, women, and also IV drug users. The thing with the TAF FTC combination is that it hasn't been studied in heterosexual women. So, and then there are also studies to show that the concentration of the drug is low in the vaginal secretions. So for heterosexual women, it would have to be TDF FTC. And as for the cabotegravir, the IM one, so you do the shot, 4 weeks later you do another, and then beyond that it's every 8 weeks. And they would have to come to the clinic for that. Next slide, please. So follow-up care for the oral regimen, as I said, we have to see them every 3 months, and we actually do HIV testing every 3 months. And it's not just the antigen antibody testing, and that was the original recommendation up until we had the updated guideline. And right now, it's also recommended to do the RNA assay as well. And the reason is because the patients who are on PrEP, the time to positivity rate when they convert to HIV with the HIV antigen antibody testing is longer, significantly longer than the 2 weeks that is usually the case. And we really don't want to undertreat these HIV infections because of a concern for resistance when we undertreat. So we really want to know if they end up having HIV. So we do that every 3 months. For MSMs, it's really each time I ask like how many sexual partners, what kind of practice, condom use, and depending on that, do we do STI screening? And depending on the sex they practice, swabs for the throat first and or the rectum too. Next slide, please. Next slide, please. Okay, so, and then for every 6 months, it used to be previously we did kidney function every 6 months, but now it's only 6 months if someone's older than 50 or the creatinine clearance is less than 90. And then as for patients who are younger than 49 and creatinine clearance of greater than 90 at baseline, it could only be annual. As for the FTAF regimen, as I mentioned before, that's the one that causes weight gain and rise in lipid profile, LDL. So that's why it's recommended to do annual weight and triglyceride and cholesterol levels. Next slide, please. So for the cabotegravir, so it's, at 1 month when they come back for their first visit, we do the HIV testing, and every 2 months when they come in, we do the HIV testing, and then this is at least every 4 months. At least every 4 months. You could do it every 2 months too, depending on their risk. But STD screening at least every 4 months for the MSM group, and they say at least every 6 months for a heterosexual group. Next slide, please. So for the trend in PrEP prescriptions, so 2014 to 2019. In 2014, it was 0.7% of the providers who did PrEP. And in 2019, it's 4.3%, so significantly more. Primary care physicians, 1.8 to 13.6, so but higher, but still about 1 in 10. Among ID physicians like me, I would have thought it would be higher, but it's 14 to 34, just a third. And a number of PrEP, so the providers increased from 9,600 to 65,000. 2/3 are physicians, some nurse practitioners and PAs, and mostly in the urban areas. Next slide, please. So right now, about 1.2 million people in the U.S. would qualify for PrEP, but only about 25% get it, which is higher than the 3% in 2015, but still there's room for improvement. And then during that time, there was some decrease in HIV, 8% from 37,000 to 34,000, but still, significant newly infected HIVs happening. So on your right, so that's the graph. So right now it's 25% overall. The goal is to get it to 50% by 2030. And as you can see, there is racial and ethnic disparity. So right now, for a white population, it's 66% already. So we're past that 50% goal of 2030. But as you can see, for the Black African American population, it's 9%. And for Hispanic Latino, it's 16%. And these are the populations who are not only, they're not getting PrEP, and at the same time, they are the population that are getting newly diagnosed HIV as well. So these are the population that really is important to get it up to that 50% so that we have less HIV infection. Next slide, please. So I think most of you maybe practice in Washington. So PrEP medications could be expensive. But there is a program through Washington Department of Health to help out. So this is actually their website, and they'll cover for medications and for labs. Next slide, please. And then actually the eligibility is pretty similar to what I went over with the CDC recommendation. Before, the providers had to fill out some of the parts, but right now when I looked at it, it's really it's the patient. The patient could put in their insurance, their income, and their risk factors, and then send it into Department of Health to see if they qualify for this. If they do, their out-of-pocket will be zero. Next slide, please. So that was PrEP. The next one is PEP, so post-exposure prophylaxis. Next slide, please. So this one is for people without HIV who might have potentially been exposed to HIV. So do they qualify for a 28-day post-exposure prophylaxis medication or not? And it depends on the risk for the HIV acquisition. What was the exposure? Number two, we have to start that medication as soon as possible, and if it's been 72 hours, we actually don't start that medication. And then do we have any information about the source of the patient? Next slide, please. So this is the estimated risk of acquiring HIV depending on the exposure. So if you get a blood transfusion from a blood product that's infected with HIV, there's a 92.5% of chance that you acquire HIV. It's not 100, but it's very close. For people who share needles, 63, but that's 0.6% per event. And for needle sticks, for us healthcare workers, it's pretty low. It's 0.2%. So the risk is pretty low, but it's not zero. For sex, by far the highest is receptive anal intercourse. So 138 out of 10,000. So that's about 4% per act. And the others are much less, whether it's receptive or insertive penile vaginal intercourse, oral intercourse. They don't even give us a number. It's low. Next slide, please. And then there are others too: biting, spitting, throwing body fluids. And they also mention sharing sex toys. Those are not. They don't say it's zero, but it's negligible. Next slide, please. So the risk for HIV acquisition, it's substantial if there's blood, semen, vaginal secretions, rectal secretions, breast milk, or any body fluid with visible blood, but negligible with urine, nasal secretions, saliva, sweat, or tears without any blood. So next slide, please. So for patients who have substantial exposure and they're within that 72-hour window, they do qualify, or if they're interested, in these medications. So the top one is for ones whose creatinine clearance is greater than 60. So it's a tenofovir, emtricitabine, plus it's not. So that's the part we use for PrEP. Plus, for the preferred, we add an integrase inhibitor. Or the alternative is to add a protease inhibitor. So these are regimens that we use for HIV therapy as well, which we continue for 28 days. The lower half, the only difference is that their creatinine clearance is less than 59, and instead of tenofovir, emtricitabine, we use AZT3TC, zidovudine, lamivudine. But the integrase inhibitor, the protease inhibitor part is the same. And patients take this for 28 days if they could tolerate it. Next slide, please. And these are just a table of what tests that we order for baseline. And for exposed persons, we actually do not, when they're done with 28 days, they're done. But we have to continue to do lab testing to make sure that they don't seroconvert. Next slide, please. So there are times where PEP fail. So number one, if it's not started within 72 hours. Number two, if they're not compliant or they can't complete that 28 days. Number three, this is very rare, but could the virus be resistant to the regimen that we prescribe? And then number four is the most common, unfortunately, in studies where they seroconvert at 3 months or at 6 months. And that may be because maybe while they're on PEP, they're okay, but they have ongoing exposure following the PEP therapy. Next slide, please. So last part that I'll be talking about is HIV treatment guidelines. These are like hundreds of pages. So I'm just going to go over some of the updates over the most recent updates. Next slide, please. So first, survival curve for persons with HIV. So the top one is the population control versus ones who have HIV. So over time, as you can see, it starts in 1995, but each time period, we're getting closer to the population controls. So with that, when I see patients with HIV, it's not like the death sentence that they had when they were diagnosed in the 80s or 90s. What I tell them is, well, it's not good. You certainly don't want it, but it's a chronic disease. It's just like high blood pressure or diabetes, where if you take control and take your medications, you'll be fine. Actually, their lifespan is very similar to population controls at this time. So that is what I tell them, but they have to take their medication though, because if they don't, obviously they won't do well. Next slide, please. So there are guidelines for this as well. Next slide, please. So with that, so what's recommended now is everyone with HIV should be on ART. And the other thing that's new is that they should be started as soon as possible. I remember when I was training 20 years ago, we were waiting, well, if the CD4 is over 500, we just wait and see how they do before we start medications. But nowadays, the medications are so good and well tolerated that we feel that everyone should be on HIV medications. The other part is to starting really right away, even before the genotype come back. It really is important to make sure that they get the prescription and that they have a follow-up with wherever they're going to go for, so that treatment adherence is emphasized. Next slide, please. So these are some of the baseline labs. Making sure, STI screening, immunizations, things like that, and other, CBC, the regular routine things that we test for. Next slide, please. So these are some of the regimens. I won't go into too much detail, but so top one, the second one, and the fourth one are 1 tablet once a day. Number 3 is 2 tablets once a day. So the regimen is much easier to take right now. There are some caveats like the HLA-B5701 testing to make sure they don't get abacavir hypersensitivity. There are some medication in here like the tenofovir or the emtricitabine that would cover for HBV. So we want to make sure that they do or don't have hepatitis B, and that would change the regimen that you could use. And the dogma was that we had to have 3 active regimens, but as you can see, the last one, it's only 2 medications. So right now, that dogma is gone. There are times that we could use 2 medications that are active, but as for those 2, for that one, if we're going to start patients on that, we do want to make sure that the genotype is back before we start a patient on that regimen. Next slide, please. So this is my last slide before the summary slide. So U equals U. So I kind of alluded it earlier before, but HIV, so someone who has a viral load of less than 200, so they would not be transmitting HIV to their partners. So undetectable equals untransmittable, untransmissible. And someone who's started, but we want to make sure that they're stable. So want someone who's starting on ART, we would say at least 6 months. But patients who have HIV but are undetectable would not be transmitting HIV to their partners. Before maybe 15, 20 years ago, we would say, well, the viral load is negative in the blood, but how can we know that there's none in the semen or the vaginal secretions? But there has been multiple serodiscordant studies in the last 10, 15 years to say that there really has not been any transmission of HIV in this population. So it really empowers the patient to say that yes, they're taking care of their HIV in their body, but also not transmitting it to others in the community. Next slide, please. So the last slide, so this is a summary. So I went over things very quickly. So HIV testing, so really the main thing take home is it should be routine screening. And you shouldn't be doing risk assessment and just testing if they haven't done it. PrEP, there are 3 medications right now, but it's not just the medications, but really doing the counseling and the STD screening, because I tend to get those chlamydia infections or syphilis, positive syphilis testing, and for these patients, because they are at risk, unfortunately. For PEP, so PEP are the ones who are exposed to HIV. So If they come within 72 hours, they take a 28-day course if the exposure was significant. And as for treatment guidelines, so it's a lot easier, and also, so it's indicated for everyone with HIV, and it should be started ASAP. Thank you.